Hi, welcome to XReality Podcast. I'm the host, Dominic Wu. Each week, I will have conversations with industry leaders to explore the unexpected connections and opportunities between diverse sectors in the world of spatial AI and XR. Today, our guest is Alaa Youssef, a postdoctoral researcher at Stanford. Alaa is currently working at Stanford as postdoctoral researcher. Her current research focuses on ethical implementation of AI systems in healthcare, including quality and safety evaluation of AI systems. Alaa's research aims to facilitate the safe deployment of AI in complicated clinical environments to advance patient care. Previously, her experience include patient-centered care research, digital health, and program evaluation. Thank you, Alaa, for joining us today.
It's a pleasure to be here today. Thank you for having me.
Yeah. What's your journey of being where you are today?
Yeah, so I would say I have quite an interesting journey where I did not start in AI research. I started in data science and clinical health research. And really, I was interested in understanding why do we fail at the health system level to achieve the quality metrics of care that, we want to improve population health outcome, we want to improve quality of care. And despite that this has been an ongoing problem, this called the quality chasm, we have been consistently failing to achieve that. So my PhD started with a question of understanding how does health system and program structure affect outcomes, patient outcomes or population outcomes. And I use data science tools to be able to see long-term outcomes based on how health system or health programs are being structured. Working through that has opened my eyes to the gaps into the electronic health record, to the messiness of the clinical data, and to the challenges of building fair algorithms to be able to really advance population health. That kind of opened my eyes into, oh, AI is big. How are we integrating AI if our base and infrastructure and data that's going to be used to build algorithms is not really in a good quality? And I was very fortunate to come to the Stanford Amy Center, where they are a hub center at Stanford where they do clinical research as well as machine learning research in AI and medicine. It spans from imaging to all types of specializations. And I had the pleasure of working with pioneers in AI, and I really have learned so much. I've learned so much on the technical aspects of what are the technical challenges of building computer vision, NLP algorithms. How do you go around that? What are the potential issues that could go wrong? And much of my research has focused on ethics and clinical evaluation to understand where can things go wrong in terms of user interaction with these tools. And so far, I have also helped build some educational programs because I'm really passionate about STEM and promoting that for future women and students to get into AI and medicine. So I think this is just briefly captures where I really came from. And I think the biggest highlight of why I really enjoy what I really like is I always like integration and interdisciplinarity, and AI is just the perfect environment of being able to work with developers, computer engineers, faculty, technical folks. Like, it is incredible at how you have complex problem as well as diverse teams to work with. So that's really fun.
Yeah, so you mentioned a lot of different fields, and it's amazing that you are specialized in different fields. And I think the world right now, we are, before we had a lot of specialists who work in different kind of sectors. But for the higher level, I would say right now you see for the healthcare, we need to start thinking about how to integrate with ethical, how to integrate with automation or AI in the clinical environments for the workflow. So we need more people like you to understand all the different sectors and bridge the gap for different sectors. So previously you mentioned that you implement ethical. So how do you approach the ethical challenges involved in healthcare? and how, like, what's your approach? And also, do you have any study case that for the implementation for ethical?
Yeah, so this is really great question. I think the one thing that's kind of like is really special about ethics when it comes to AI or biomedical technology such as STEM research and regenerative medicine is you start to see the ethical questions of what has been in philosophy around beneficence, no harm, materializing into tangible outcomes that you can see and measure. And one of the aspects of how you approach this is you need to understand that like when you're looking at ethical problems, you cannot look at it just down the pipeline. You really need to start with the question of what was the intent of being developed? Who is the population? Who's missing out of the population? How the data was cleaned? And so I cannot claim that I have built all that infrastructure of knowledge because this has been evolving with a leader number of scholars and people who have developed frameworks. But what what my research has really developed on is, for example, understanding how clinician labeling can introduce bias into the algorithm. Let's say, for example, in radiology. In radiology, we have a lot of imaging data. We need few data that are labeled by experts. And one of the components, and it's not unique to radiology, is we as human beings have different levels of perception of what is the ground truth or what is the label. If I'm saying this is an apple and this is an orange, it's clear. But in medicine, things are not that clear. And so you can see that people have different perspectives. If you have the different perspectives and you do not assess for it in the building and training of the model, you reproduce the main common way of how a clinician has labeled the data. So this is a cause of a labeled data source. There's other aspects of bias that could be introduced because your health system is not diverse enough. You do not have representation. And once you build a model, you're trying to deploy it in a context which is very different. And so that can lead to problems in terms of implementation that you can see into patient outcomes. So to summarize, I think there's different aspects of where bias can be introduced in AI and where it can lead to, where it can lead to ethical harms. There is a number of frameworks that exist. And our goal, for example, is how can we use the frameworks that exist and what we learn from the existing use cases and the use cases that are increasingly being deployed to better understand the ethical issues that are happening when we conduct this type of research. One of it component of it is, for example, the Stanford healthcare. There is the data science, the data science health team, and have the fortune of being working with Dr. Dayton Char, Michelle Mello, and Lancy Downing on, for example, looking at use cases that are coming for deployment and evaluating what aspects of it really leads to what are the ethical issues that are in this AI solution. How do we identify for it? How do we anticipate the future things that could happen? You can think of it as an example as, for example, let's say, for example, we are implementing an algorithm into the clinical workflow of a radiologist. And if the radiologist is not informed or like during busy time, there is increased risk of automation bias. You need to understand what their workflow look like. You need to understand what are the situations where the AI can really reproduce that. And also there's a tension, I would say, between ethics and legality, because in long-standing medicine, like liability is a major factor. And the problem is physicians feel the ethical burden of needing to ensure that the AI is safe when they do not have the information to vet that the AI is safe. And so what you end up with is you have the technology, but you have resistance because people are not trusting that the technology is safe. So I think these are also some of the things that the type of the work and analysis I do really kind of uncover.
Yeah, wow, this is amazing explanation. And yeah, I totally agree because if you see that, I remember a few years ago, I went to a doctor and I had a surgery in Taiwan, and I saw doctors still using pen and pencil and write something, and nobody really understand. And I know one of the very hot AI product is called Doctor Diagnose AI Assistant, which record the entire conversation and start making a summarize. And later on after the each diagnose sessions, it will have like something that have like a summary and also like written down very nicely and organize it. And that is right now a very hot topic that people are trying to implement into it. So yeah, go ahead.
Like on that point exactly is like everyone is very familiar with the jump of large language model, ChatGPT, Bard, and all these models. These models have shown like it's almost a new revolution in the world, but also in medicine tremendously because it can address, note taking is and billing is very something that's very burdensome for clinicians, and that leads to burnout. It has the potential to do that, but we also know from the technicality of it is that these models have the risk of hallucination or fabricating information. So
Mm.
let's say, for example, it reads the conversation,
Mm.
but for a patient who has, not very good, like English is not their first
Oh,
language,
yes, yes.
it can record something different, or it might miss something compared to another patient who's very good in English and speaking English. And as a result, something important can be missed out of the record that the physician, when they're reviewing, they have not seen it. And so you start to realize how inequities and how challenges in the design can actually influence outcome and lead to harm.
Yeah, so echo your point that, for example, if the designer or developer creating this product, maybe at the end, doctor has to prove it. And
Exactly.
maybe when proving it, it needs to be at when the time when doctor's memory is still fresh. For example, after the conversation, it has to automatically generate. And before the patient leave, the doctor has to read it again and then prove it. So doctor has the chance to reconfirm with the patient. So maybe that types of workflow is very important to be trained and implement into it, because just echo what you said, that there might be some hallucination or some, for example, accent, right? For long time ago, when I probably like 5 years ago, I used Siri and I talk something, and Siri always kind of misunderstand my accent and do something else. So maybe there might be a way to correct it, or like yeah. So I do think that the workflow is very important, because AI, even though is very convenient, but there the hallucination part and also misunderstanding or missed any important stuff. It's just a tool. It couldn't really replace totally, and we need to reinforce some potential issues or potential harms that all the procedures or workflow need to reinforce to ensure that the note taking or some other AI later on automation or kind of like a assistant to really helps our yeah, our like a diagnose or healthcare sectors. Yeah.
Yeah, absolutely. And I think one of the things is like most of these large language models have been built on, like predominantly English language. But also, if we talk about pronunciation, you need to ensure that your training data have the different accents, have the different languages in order to be able to really capture accurately what that. And it's important to understand that, patients who have accent or patients who have English as their second language tend to be the patients who have health inequities. And so if these are the
Oh.
types of patients, they're likely to have, their quality of care and experience is going to be different. Their outcome might be different because something are missed. I would say that clinicians do absolutely their best to kind of like read the notes, but as we mentioned previously in our previous conversations, is that the work environment in medicine is really chaotic and there's so many things happening. So the clinician might have a patient after a patient that they might not get a chance to really sit down, review, and authorize and approve. They might need to do this in between 3 to 4 cases. And so the standardizing that workflow isn't in itself a challenge. And so these are things that we need to start thinking about and need to understand where things can go wrong and where can we build safety measures in terms of our practice to ensure that these tools are not resulting in harm.
Yeah, so yeah, I totally agree. And also, how do we implement like a AI into like AI system into existing clinical workflow without disrupting the work of healthcare professionals? Do you have any study case, or what types of training or support do you think is necessary for healthcare professionals to operate or to do it effectively using AI system?
So to give a context to the audience, usually how things flows from being developed into how being translated, we know that you have the training data. Let's say you build your algorithm. Now you need to get this algorithm in, most of it has been built on retrospective data. Now you need to do a clinical reader study where you are trying to see, okay, so if I train the model makes a prediction, the model produces an output. Is that output equivalent to what a medical expert is going to produce? Let's say, for example, that check mark is done. Great. We need to do prospective evaluation where we need to see that if the model runs, these are the likely outcomes we can see because we all know about, distribution shifts, population shifts. We need to understand the behavior of the model when things are not, like as in a retrospective study where you know all the variables. And so most of it relies on, you need to do silent deployment, which means running in a simulated clinical environment, how the algorithm is going to produce output. It's not affecting patient outcome. The clinician might not be seeing it. It's just showing you the output. And then you do a comparison to see, okay, so if I compare arm A, where it's the standard workflow, and arm B, which is the AI workflow, is it comparable, or did the AI arm miss a lot of things that a medical expert has captured? Alternatively, there could be otherwise. And the outcome of that is that the clinical team makes a decision whether they think this tool and the level of risk and error is tolerable or not. And they make a decision whether they want to do this as a prospectively to deploy and start monitoring the outcome. It's very important to know that AI requires, as part of it, continuous monitoring and evaluation. And the real challenge of where we are in medicine, where we have not solved the problem, is what does that monitoring and evaluation look like? Do I stop the algorithm and monitor and evaluate after 1 month? Or what is the threshold on when I pull the trigger off and say this algorithm is not performing well and we need to kind of like pause it and retrain it, for example? Another important factor to consider is when you're deploying the algorithm in the silent phase, it starts to show you factors that you might not have captured in the retrospective study. Let's take one practical example, and this is a research paper that has been published with colleagues here at the Stanford Amy Center by David Van Leeuwen and senior author Akshay Chaudhary, where they took a large language model. They looked from proprietary models as well as open source. They selected the best language model that had the best performance in terms of clinical task summarization. So can the LLM summarize radiology report? Can it summarize patient notes? And they did some sort of, like evaluation, and they find that if you adapt the model with prompt engineering, it does better. So they did that. And once they kind of like measured the accuracy of the model compared to the clinical expert, before they deployed, they did something called safety analysis. And that's to evaluate whether the model is ready to be in clinic or not. What is really fascinating, and I think a main takeaway for many people to pay attention to, is sometimes we perceive that AI need to be 100%. When there is nothing that is 100%, even at standard care, we already have a percentage of diagnostic error. So if the AI can, excuse me, if the AI can produce, like a higher quality of care with less percentage of error, then that is better than the standard of care right now. For example, they found that if we compared the likelihood of an error or in the medical note that could lead to patient harm, whether severe, moderate, or mild, and they looked at medical expert. And when they compared, they found that the best performing model had a lower likelihood of errors and harm compared to that of the medical expert. In that context, you know that, an algorithm can be helpful if it's adapted right, if it's evaluated right, and if it's implemented right. And so I really kind of find it challenging that people take it as a panacea that, AI is doing well, AI is doing bad. It always needs to be in comparison to what, tell me what you're comparing it to and what are the things you have evaluated it on.
Wow. So basically, what you mentioned is that compare with the profession or experts of the healthcare doctors, they find out that the AI model will cause lower harms than the experts' opinion. I think this is great because for healthcare, it's all about like a reduce the risk, right?
But
So I think this is great. So what you said that um, AI doing great, doing wrong, it all depends on the context. What are you going to compare? So yeah, so there's comes another issue with that. For example, AI is very convenient, and later on, pretty soon, I believe we will all implement AI into our workflow. And just echo what you said that ethics, right? Different people with different accent that also need to be take into the consideration. But right now, if you see OpenAI has used Scarlett Johansson's voice becomes one of their default voice, named Sky. So pretty much right now, if you see the best AI model, a lot of people even said that, oh, we will protect your privacy stuff, right? Even though on the company website, but if they say, oh, we integrate with OpenAI, we know there might be something that the data will leak. So according to your vision, that for all the healthcare, they has to use some source such as OpenAI, the big company source, Meta, or Apple's AI, or everybody needs to develop their own. Like, what do you see that types of things that how can we utilize AI but while protect patients' data?
yeah, so this is definitely a very critical area in medicine where for a long-standing issue, you have a large number of AI startups and companies that produce health products. Excuse me, but there is very few of them that has been deployed. And if you ask the question of why, the question is
Mm,
that have
yeah.
the obligation to protect by HIPAA, they have to protect patient information and patient privacy. And so for a hospital to build a contractual agreement with a vendor, they need to ensure that their measures that their patient data is not going to leave the place or is going to be safely processed. Now, it's important to note that exactly the devil is in the details when it comes to third party, because when you are like when you are many of the Gen AI that, for example, for mental health or other things like that, if you look at their policies, they have a third party, which you don't know where the data is being subjected to. But it does not fall under the traditional coverage of HIPAA, which is like the policy or regulation that regulate patients' privacy by the federal law. So I think it's a very hot topic where people are starting to realize that, regulation is very tricky because how do you, if you're building on open algorithms, if there is data leaks, all of this information, how do you ensure the data is being de-identified? And one example of this, of how hospitals have came across is, for example, many hospitals have implemented their own servers, secure service API of access to GPT, so that clinicians and people in the clinical environment are not using the commercial products where, for example, data leakage could occur. So I think this is an area where it is challenging, but it's important to understand that in medicine it's a bit different than in industry, in general industry. And I would invite audiences to, like read the policy when they sign in a policy for an app, when they sign for a policy for anything. You will find so many, specifically people in California. There is a lot because California has also, like you see this in your cookies agreement where, like, do you deny or do you select, like you manage your preference because it's by law that they have to inform you that they're using that. So if you read the terms, it's really complex. It changes based on how the regulation change. And I would say that the landscape is changing quite quickly. So we don't know what policy is going to exist, but I would say that hospitals are very secure and very protective in terms of making decisions about using products, because they must ensure that they protect patient safety first.
Mm. Yeah. So what do you foresee in AI for digital health over the next decade? Like, what do you see, like how AI implement into digital health or healthcare or clinical health? What do you foresee that AI being implement?
Yeah, I think one of the most tangible things I can see is, we all know that before AI became big, digital mental health was really big, because there is an increased need for mental health access, and there is a very low, like there's a very high demand and very low access to mental health care. And so we know that 1 in 4 people will have depression. We know that, like statistically, we know that there isn't enough of mental health professionals. The challenge is, digital health interventions has shown to be um, to have clinical effectiveness in interventions during COVID-19, during other places, to show that it can improve actually patient outcome. Now, all this was before AI. Now that you have AI that can, or generative AI that can be part of these health products, you have an immense potential of these things, having conversational AI that talks with you about your mental health. It acts as your therapist. It can act as in, like it can um, be something, like you always, now when you go into the chat, you interact with something that is a chatbot. And so there's going to be elements of medicine that is going to be more onto the automation component. And, initially people would have a bad experience with chatbots, because they were, like they were kind of like trained on specific answers. Yes, no, let me find and assist someone to assist you. But the generative AI is very different. Generative AI has a conversational aspect that mimics that of human behavior. And so I think AI is going to be big in terms of digital health, and like advancing the quality, but also, carrying its own risks. The second aspect of it is, it is going to expand and transform medical practice in hospitals, because it allows you to analyze broad streams of data. It allows you to map. So, for example, um, we know that, like models can be. So in medicine, you can imagine, let me give that example. In medicine, for example, there's something called foundation models, or similar to the large language model versus a fixed model. You can train a model to do one task, but when you train something like generative AI in health systems, you can train a model that can do many tasks, and that can save workflow in terms of billing, in terms of patient clinical notes, in terms of responding to patient messages. And so there's so many aspects of where AI is going to integrate into the health system, and actually advance the digitization of the health system. Many of the things is going to be more even digitized. And so it's going to be a different sort of experience. And I think it's important to think, where are places where there isn't infrastructure, so that they actually have access to digital health. And like we know that inequities in data in infrastructure can affect, people having access to digital health. And so it's important to think of that right now, because in future digital health is going to be the I think primary component in medicine.
Wow, yeah. So for digital health, you mentioned that we need to implement more like a kind of like the model and help people to solve more like a mental health. And as far as I know, that I did some research about recently Gen Z. Gen Z had a lot of mental, like they need a lot of mental help because you see, like right now, all the big companies are kind of laying off people. So, and Gen Z serve as more like a new generation and trying to get into an. And if you see, a lot of people said that AI automate or AI replace a lot of mediocre workers, which means that AI can pretty much do a lot of things that junior people can do. So Gen Z really needs a lot of like a mental help, and for the kind of like the mental health, digital mental healthy integrate with AI, do you see that types of, for example, digital human with AI can help with like a, for example, consultation, or what types of forms do you think that it will help the people's mental health? For example, consultation, or somehow like a game, immersive games. What do you see that AI like? Do you have any study case to help people in general?
So there is now research that's being done on how you can use generative AI in mental health. And I think it's very important to recognize that different people will have different level of preference to seeking, whether they want to have a conversation with a digitized chatbot versus, seeing a mental health provider, and having that connection. Mental health is very unique and that some patients need that connection to feel safe and be able to open up. Others feel, being able to talk to something that is not human, provide them with, more room to be more open and disclose things that they would feel ashamed or disappointed to share with a provider. And so you will have different aspects of how people interact and perceive the preference of using these products. I would say the one component of it is these things need to be developed thoughtfully. It needs to include experts who can vet that it is good. And I think there needs to be a level of regulation that kind of regulate that these things are safe for people to use, because there has been many cases where, like the chatbot will tell someone to do something that would lead to patient harm. This isn't
Yeah.
this specifically in the context of mental health. Now, the other aspect of the question is related to who's going, like what is the model trained on, what is it really functioning. There is going to be the digitized component, but I don't know if I cannot tell, like again, it's going to differ from people to another, but you can see that, you can still have access to your mental health provider, but imagine instead of needing to do with your therapist, like the exercises alone, you have something that can help you explain, that can make it more interactive. Let's say, for example, in, like in cognitive behavior therapy or interactive behavior therapy, there's some sort of exercises that the therapist might assign to the client or to the patient. Imagine if you have something interactive. There has been so many health apps that, can help you check your mood. You can feel not alone. Like we all have our ups and downs days, and you get to see, even if you see a mental health provider, you see them once a week. You see them, like if not more, if not lower than that. And so imagine if you need something that kind of checks in with you, that helps you keep in that mood check. Again, there's a component of how data are being handled by the companies that produce these products, but it can immensely have an enormous impact on people's mental health and help them achieve their goals.
Wow. So pretty much the AI, Gen AI will help bridge the gap for the like the healthcare provider to assist with patients' mental health. And also it can be different forms according to what the patient or the person likes. And recently I saw there was something called AI tutor developed by OpenAI. They created somehow like a real person and talk to you, or sometimes it serve as a chatbot. And they find out that students are more open to the AI bot than human. Why? Because I saw the first release model was from what was to Japanese audience. And if you know that Asian people, their teacher, their the parents have a certain expectations to their child. So when child asking like, oh, what's the Korea like questions, they usually trying to redirect the child to whatever they are looking for, which is totally not really follow what child wants. So they feel less pressure to talk to the AI tutor. So I think this might help us to kind of eliminate the bias. Yeah.
And I think it's also going to if used right, as it's now, like there has been this big hit of a Gen AI in education, in elementary and earlier education since last year. There has been several interventions and ways where Gen AI has been shown to actually improve patients, sorry, not patients, improve students' learning and learning outcomes. You can imagine for people who, like English, for example, is not their primary language, how these tools can help them, lower the amount of time they need to kind of like edit. And, if they feel, for example, disappointed to kind of seek input and have a lot of errors and see that errors, they're more open to learn. And so it can help people think in creative ways if they're reflective and building that into their learning itself. I think that's a big component. So again, anything has a benefit and harm, and it's always how do we balance and how do we optimize the greater good and minimize the harm that can occur.
Yeah, so just like you said, that everything has a good side and bad side. And I recently listened to Khan Academy's founders. He wrote a book, and I usually use the audiobook version. He mentioned that the Khan Academy has a Khanalami or something. Yeah, the chatbot inside Khan Academy. And then people can kind of, for example, like, oh, I want to talk to the somebody who has already passed away, for example, like Great Gatsby, right? You are the Great Gatsby, and the student will ask, like, for example, like, what do you mean that your eyes shine with green lights, da 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 da, like asking some parts of the book, because student doesn't really know what does that mean. And student wants that the chatbot to play the roles for Great Gatsby, and having a conversation with the student, and students knows better. And for example, students can talk to somebody who already passed away, such as, Lincoln, right? Lincoln, President Lincoln, or some other people, Napoleon, right? So, for example, like ask them, like, what do you think about your life? Da 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 da. And I understand that sometimes there might be some hallucination, but overall, I can see the chatbot is getting better and better, and all those can really help students to have like immersive learning and also learn things in different ways, and also give like instant feedback for it. I think those are also a really great way of learning.
Absolutely.
Cool. And what do you see the spatial AI or XR AI in medical, for example, training or clinical practice? Because before we were talking about AI, but XR, which is AR, VR, MR, that includes computer vision, and display some simulations in real world, real time. So what do you see that XR AI or spatial AI in healthcare sectors?
Yeah, I think this is an area that has been really fascinating for me to explore. So, like we have been fascinated by the computer vision algorithms and AI and how its ability to interpret things and detect things from the images and the pixels. XR and VR traditionally has been used in medicine to train people to see simulation of how, for example, a patient might be rolled into the ICU. How do we resuscitate patients? What is the journey of a patient going into surgery? There has been many ways of how we use virtual reality to train trainees. Now, XR provides a higher raises the bar in terms of the experience of learning and thinking, because the high quality simulation really puts you into the context of the situation at a higher level. And so we know from we know from neuroscience that there's something called mirroring neuron, which is if I watch someone do a behavior and I'm not doing it myself, it is going, and that's why we use those tools in educations, because we believe if there's evidence that if people see the behavior and understand it, that is going to lead them to behave in a certain way when they are in the real situation compared if they have not. But I have seen recently many aspects of gaming and many aspects of situations that are being developed with XR. That's a really a very high level. You're really mixed with reality. You're moving things. You're seeing things with your own hand. You're seeing objects. It's not just that you're watching something. And I feel that is just truly immersive. Is truly. Can you imagine? Being able to train for surgery and really practice with your hand and see how your hand is moving, recognize so many of those things. It's just actually putting you into the context of training and learning. And this can help people train faster and have room for practice. Because usually, like you have a limited amount of training and you need to go to rotations between surgeries so you can advance your skills. The question becomes resources, because these development of these things and making it available to training is expensive. So I would say availability in simulation is a major barrier. Medical schools do definitely invest in that, but like it's a rotation component where some people finish and then some people come in to practice on that. So I see that this is a component, but I see that the future of training is going to be more towards the simulation and to more towards the practical, seeing, because we want people to think. It's a different thing when you read, and it's a different thing when you see and are in the situation. When the exercises prompt you to think about something, to see something, to witness something. You can imagine, there's a lot of it related to like patients who have like neurological disease. Can we use XR to actually help them, like strengthen their memory, or to have a better, like orientation? I feel like the opportunities are so vast in terms of like, and there's a need for clinical research that really brings that. How can XR help patients with depression who are on isolation, with mental health? We were just talking about mental health. Can we have tools that really helps patients with mental health or educational disabilities or educational difficulties to have more tools that allow them to learn? I think that merge is exponentially promising, specifically with innovation in AI. I think AI and the innovation in models and computer vision, these algorithms are just going to get better, and how it integrates with XR is going really to advance the level of experience for people.
Wow, this is amazing. So, pretty much what you said, that the future of the healthcare or mental health is more like about the training and put people in the simulation. So, by actually doing and immerse yourself in the situation, you learn more and you get more, and you will be keep evolving. And AI can also help us to see the prediction and know the consequence after the student make the decision. And also I the teacher would rather the student try and fail inside the simulation rather than in reality. So I think spatial AI or XR AI definitely help this area. So we know I know we have a lot of like a junior like a XR developer, or a junior like a healthcare, like a people who just study the clinical or like a healthcare. So what advice would you give to the researchers or XR developers who are just starting out the field of AI in the healthcare? Yeah.
So do you mean for developers or for clinical
Yeah,
training?
like in general, like people who are from different backgrounds wanna jump into this multi-disciplinary field.
Yeah, I always see it as a language that you get to understand. We all use the same words, but we mean different things. And so I invite developers to immerse themselves into the healthcare environment, into the clinical environment, to understand, what is the real problem that usually ask to shadow the clinicians, ask to be in the clinical workflow, ask to see. Because now when you go in to produce something, write a code, you now have a better visualization of what that really looks like. In contrast, for clinicians and people in research, we need to understand how, developers code, translate the clinical problems we're seeing. We need not just to be seeing the algorithm output, we need to ensure what does the code mean? What does that conceptually mean? So I invite, junior trainees and people in research as well to understand what AI and virtual reality is. What are the basic fundamentals of it? Because now that you understand the basic fundamentals, now that the junior developer or engineer understand that, when we sit at table, we can have a conversation. And everyone's perspective is going to be valued. Everyone's perspective is going to be helpful, and we can truly solve the problem rather than discovering it post hoc. So many of the things that we have seen in research of why things fail in implementation is because people define the problem in a different way than what the user expect. And when the user get the product, it does not really match the expectations. And so you have the fact that, no, this is not what, it's almost like, I'm giving you something, but this is not what you really asked for. So understanding what we're really trying to develop and what is the intended out product and agreeing on the out product in the beginning is super important. And to get to this point, you need to be able to understand each other. You need to be able to ask the right questions to each other.
Wow. So you encourage the researcher and also the developers to understand each other's fields and potentially immerse themselves, for example, like go to clinic and see their workflow and work together and understand what's the real world scenarios. And the researcher needs to learn more like AI and also XR parts. So everybody
I
can,
mean,
yeah.
like our conversation before this podcast, I have learned so much from you, speaking about XR and how do you go around, building and modeling and like thinking about how you approach the problem in XR. This is very helpful for me because now I understand if I'm having this conversation, oh, this is like the things because let's say, for example, we're talking about, I might see that something I can tell you if I'm asking you to develop for me an XR product for me to use in clinical practice. I might not know that some of the details I'm not mentioning is important for you in terms of context, in terms of setting, in terms of that there is there is an ECG in this place. There is hazardous harm, like this we do not transfer patient onto that side. If I don't tell you that context, you might create a context that does not really mimic the truth.
Yeah, right.
So understanding on both sides what is important in the development can help us see, yes, so relevant to that aspect, I would like to see this.
Hmm.
And other person's going to be able to ask the right questions as well. When you develop for me the product, I need the product to help me do task 1, 2, and 3. So I really have learned this lesson a lot, collaborating on multiple projects and really understanding the language of what they are working on. And that's why I'm embedded in technical labs as well as in ethics labs, because I believe that, understanding the language and the technical challenges allows me to be able to go back and have, a realistic look at how I think about ethics and cognitive science in practice.
Yeah, so just like you said that for a developer, and also, for example, like an artist who prepare the asset, and also the researcher or people who actually represent somebody who is the user and subject matter experts. Everybody cares different things. For example, the subject matter expert like you might very focused on the flow, might be very focused on the patient, the practitioner, and for the 3D modeler or asset preparator, they might be very focused on the vertex, how many vertex and the file size, and also what's the lighting, what's the normal, the texture, what types of style do you want, realistic or low poly? It's what they care. And also, for example, like what size or what model, show me the pictures, right? And for developer, it's more like tell me under what circumstance if it is achieved, what's the result? If it is not achieved, what's the result? Give me all the potential scenario if state, if something, and also if something is happening and leads to something or leads to not fulfill with something. So there's a coding structures that, yeah, pretty much I would say is more like a pattern or trying to figure it out what's the model. If you want to say model, it's I usually treat like the development as a big bucket, put it inside small bucket, and each bucket has its own like if state, right? Trigger, what types of things fulfill and trigger, and at the end, what's the result, right? So I think everyone's cares about different things, and people need to learn from each other's perspective and understand each person strength, right? For example, for the if XR developers want to work with the researchers will provide context, which is the content, right? And the developer will create, which is the infrastructure. Means that um, kind of make the concept to final execution. There's a gap, right? So from the ideation to the final app, there is something need to transfer. Yeah, so I think, yeah, so the collaboration will be very interesting. And besides, recently I listened to Sam Altman recently has had an interview about what he thought about the future of people. For example, like a lot of developers or like people who work on the productions got laid off just because of AI pretty much automate a lot of simple text. So the company doesn't need so many people to work on one project. That's why. And he envisioned that there will be like a one person company value $1 billion or 10 start with 10 people company value 1 billion. That's what he envisioned, but he said that maybe in the future everybody can be his or her own company or like a startup founder, and then start creating more valuable or more niche products for different sectors, right? By, for example, like you will be the head and everybody work for you are a robot or like a AI chip. So it's very interesting that see the kind of like the another industry revolution using AI, and AI really empowers us. And I know that there are a lot of things that we have to concern, but if we done it right, it really helps us for example, a lot of people complain about their job right now, right? And if they are in the job they complain, if they are out of job they complain, why not just do something that makes you feel good and also find a niche, right? And devote it yourself in something, some problems you really want to solve, and really create a product to benefit people. So that's like the interesting point. And also that's also the reason why I start the podcast and also kind of drafting a book about how can we leverage spatial AI to solve a bigger problem such as poverty, climate change, and so on, like healthcare. So I think, yeah, I mean, we are all keep working on this field, and yeah, I'm very happy to have Alaa join us today. And yeah, thank you, Alaa.
Thank you so much for having me. Such has been such a fruitful conversation and have learned so much already. And thank you for having a great conversation.
Yeah, that's it for this episode. Thank you so much for listening. We release episodes weekly. If you enjoyed this conversation, check out our other episodes on Spotify, Apple Podcast, or YouTube. Support us by giving us a follow and 5-star rating, or subscribe to our channel and give us a like. Thank you so much, and I will see you next time.